Are there any changes to today's agenda? Stuart, do you want to go?
Yeah, I think the motion to go first there, I guess.
Okay, we'll move. Gene, if you're okay with it, we're going to move Stuart's capital expenditure request. That's item 3. We'll do that right after public comment. That way he can go back to work.
Now, which capital? Oh, the radiology?
Yes.
Yeah.
Yeah.
Yes, yeah, it'll be fine.
Okay. Okay. Item C is approval of last month's finance committee meeting minutes.
Can I make a motion, or do we need a motion to go ahead and put it on consent agenda?
Yeah.
We've all gone over it, and I mean, it is what it is.
Yeah. Okay. Then we will put that on.
Second.
Okay. This portion of the meeting is reserved for public comments. Is there anybody from public comment? Is Christina employee?
She is.
Okay, and Ross is just
No public.
Okay. Okay, sir. The floor is yours, sir.
All right. So just kind of a follow up to last meeting, kind of introduce this inevitability to everybody. Was with the X-ray room kind of into life. So I've gathered a couple quotes from GE, one from Phillips Healthcare. I reached out to a couple other companies as well and had no response during the month of time between the meetings here. And so I went ahead and provided the Phillips quote. With GE, we are getting like a substantial discount with loyalty and kind of trade in, I guess, about residual value on their viewpoint of their machine. So that's about $100,000 savings or $90,000 savings. If we go ahead and go with like an alternate company to get a comparable machine, in my opinion, actually, they're a little bit less or more, right? If we went with a different company, GE's offering is quite evolved over recent time. So Phillips anyhow is about $280,000, just starting price for their equivalent room. And then GE, we can get a better equivalency for about $193. And that's with like I said, with the discounts and such. There's quite a bit of information in the packets provided and the stuff provided to everybody. But if there's any really kind of follow-up questions or any details wanted or anything, I'd be happy to answer them.
Yeah, Gene, I know you can't see, Stuart provided two quotes, are kind of just reiterations of what he had brought to the table at last month's finance meeting.
Right.
So I don't know if you have a recommendation or opinion. I mean, either way we have.
So yeah, I recommended that we go with what he's got on there to go with. There's no changes, right, from what I'm reading?
From the prior offering of GE's service, there'd be no change.
Right.
No updates from
the
time being.
Okay.
John, like if I need to a motion to send it to consent, because it is what it is, and it looks good, and we need the equipment, so we don't have a lot of choice in it.
Yeah.
Yeah, and I mean, I can make some compelling arguments for the advancements in radiology aspects and stuff like that, So, if anybody, of course, has any follow-up questions or anything about what improvements we will be able to provide and such, Okay.
Was this, to refresh my memory, was this including the table or not?
This isn't the entire room.
It's everything.
It's going to be the overhead tube,
Perfect.
the detector.
It's actually a great price then.
Yeah, the generator, everything's going to be there.
John, did you have a question? I'm sorry.
I was just asking, we have GE right now, right? That's what we're using now, GE. And there won't be any additional procedures that we can do with this new equipment. It's just because it's end of life for the old equipment.
Yeah, so the end of life status on the old equipment will make it basically GE service that we're paying for and that they can provide will be basically as able, right? So the biggest problem is the detectors are what's going end of life, and they won't have any to provide. So if we had to replace that detector, it would be a private cost for us through secondhand or whatnot, and they're not cheap part components to the X-ray room. They're about they're the substantial cost in these rooms. So the cost for replacement on those can be absorbent over time if we kind of let the issue.
Okay.
Yes, I think this equipment was used when we bought it. I mean,
yeah, it's a retrofit, right?
Yeah.
So I mean, it was produced early 2000s, retrofitted mid 2010s or whatever, the time that we bought it, you know. We did get, it was a new room, right? But it's a retrofitted piece of equipment. It wasn't designed the case it's in.
We got our money's worth out of it, then is what you're saying.
That's
Absolutely.
Yeah.
Absolutely.
Yeah.
Okay, one more question.
It's, yeah, exactly.
All those
One more
babs.
question. Is the 193 include a maintenance contract?
So that would be separate.
How
They're
much?
kind of like, they're all separate. I think currently, I'd have to get back to you on the exact cost because we haven't renewed that contract due to this end of life, right? So I haven't really looked into it. But the cost will be probably, if I had to say, the Phillips might be a little bit cheaper on service, but GE is going to be more of like a kind of a long run, right? Where it's going to take the whole life of the machine to recoup that service cost difference if we were to go with another company, basically.
Right.
So
No,
the
I'm
15 year difference, right? You know, we're not saving quite a bit.
And we've actually had great service from GE.
Yeah, and GE provides exceptional service, and they've helped us a lot with kind of hidden costs and keeping it down and stuff. So.
It's funny he didn't mention dollar.
Well, I don't have an exact dollar figure. I can provide that at a later time.
But that cost is gonna be there no matter what.
It is. It's gonna be, it's gonna be a revolving cost. It's gonna be, have to be provided anyway. And like I said, the cost, the reduced costs from other providers would, the course of the savings that we're getting initially, it's gonna take the life of the piece of equipment to recoup. So.
okay.
So the recommendation is to go with the GE.
So that would be my recommendation. Correct.
And Gene, you're okay with sending this to consent?
Yes,
A second.
Okay. Then we'll go on consent, and then if the other three board members, if they have questions about it, then they can always pull it.
Yeah, sure. I can be available for that.
Okay. Great. All right. Well, it is on consent, so.
And then I think John, I did kind of speak with Tim a little bit. And so basically at this point, this is just basically trying to lock in these costs, these prices and stuff like this, and funding, not anticipating to fund until, you know, beginning of next year, March, you know, something like that, or
Is there any-
or something.
Any effect to the building? Is there any permitting?
We do have to get permitting with, you know,
Okay.
Oshpod and all those, or, and what's the other, OSHA.
That's gonna add.
But so that's another good point you bring up, though, is HCI. The current GE offering that we have a quote on is currently approved through HCI. The Phillips is still pending approval.
Oh,
So that's a whole nother process that, you know, may like kind of delay like the improvement or whatnot.
Will it require any construction in your room to fit this in? Or is it
There
gonna go right where the
shouldn't
old one went?
Yeah, there shouldn't be any like no wall construction or anything like that. It should just be kind of like a bolt in and out, you know?
Okay, cool. And do they give us any money for the old one, or the old one's not worth anything?
Well, it's not worth anything to them in a sense, right? But they
Right.
do want the equipment back because of this end of life issue. Like, so they want as many serviceable parts as they can gather back. So that's kind of where that discount's coming from, is they'll get
Oh, I got you.
the
Okay,
Hector back.
Okay.
Right. So,
all right, that makes sense.
All right. Well, thank you, Stuart.
absolutely.
Go on consent for the board meeting.
Thank you, gentlemen.
I mean, you're welcome. if you Want to.
I think the rest, yeah, you guys can handle the rest. Thank you for your time, though.
Thank-
You guys have a good evening.
Thank you, Stuart. Appreciate it.
Happy Thanksgiving.
All right. Happy Thanksgiving to you too. Thank you. Okay, well, next dive into the financial statements. Do we want to start with John or Amy?
I think
I'll
so.
start.
Okay.
Yeah, I'll start. I'm looking at the patient statistics page. I'm not sure what page that is. I don't have a page numbers on mine.
On page 8.
8.
Page 8. Okay, thank you. Okay, we're going to look at actuals versus budget in the current month. You can see that the patient days are over a little bit, but that's still we're still under budget as far as revenue goes. And that has something to do with, if you look at the bottom of this page, our case mix index is less than budget, which means the acuity is not there, which means there's probably less charges. And that kind of goes throughout this thing. If you look at the SNF, we are higher in days and we are way higher in revenue because there was a glitch at the end of last month where some of the revenue did not get recorded in September. So it got to October. Also, another reason for the increase in revenue, I believe, is new patients require, and you could help me out on this, Mark, if you, some of the new patients may have come in, may require a little bit more testing, which it drives up the revenue, gross revenue at least. Okay, and then we have our ER visits are under budget, which is one reason that the outpatient revenue is slightly under budget. What helps out is our outpatient visits are over budget by about 82, or I'm sorry, by 116. And that's what kind of drove the outpatient revenue to be pretty close to budget.
John, could I
Otherwise,
ask you a question?
Sure.
So how do we come up with a budget number of 26 on ER visits?
26.
I mean, the admitted ones or what?
I'm looking at our statistics under the admitted ones, yeah.
Just based on prior years. We really just look at prior years as a base, and then we'll either increase it or I think we kept it stable from last year, actually. I think that's what we had last year.
I
Do you think?
don't know.
What do you think? It's too high, too low?
We've never had a budget of 26 visits in the ER. It's always been around 20. So I'm wondering how does it change?
Well, last year, I mean, for that month, we may have had an unusual, a number of patients coming in.
Okay, all right. I just
1 month, yeah.
Wouldn't the prior year be the 19 right there?
Prior year would be 19, yeah.
19, yeah, it's 19.
So
Well, we took it as a whole year and just divided it by days, and that's how we did it, really. So
Okay.
it's, we could look at that when we do the budget this year. I will look at it a little bit more closely, but that's how we did it. We just took the total from last year, divided it by 365, and then multiply it by 31 for October.
Okay, all right, thank you.
Okay. Our clinic visits are above budget, but the revenues are still, they're included, they're still a little bit below budget, and that's also because of the case mix index. The acuity just wasn't there. We have our charge master review coming up, and they are going to make sure that we are properly documenting everything and also getting the proper charges in there. They're going to look at 100 accounts. So hopefully that's going to give us some benefit and increase our revenues. That's going to be starting probably next week, as soon as we get them the information, actually. As you see, our retail pharmacy scripts are way over budget again. They've gone up again. Last month was only about, I think, around 5,000, I believe. Let me have it here. But anyway, it's about 50% over budget right now, and the revenue is about 65 over budget if you look on the income statement. So that's continuing, and Suda tells me this is going to continue to grow. I would think that at some point it levels off and you run out of new patients, but maybe not.
All depends on how many writings still has left.
Actually,
Well, that's it. We'll take every last one of them if we have to. You're right.
Yeah. She sent me an email earlier this week that she's getting patients basically coming and crying because they want to move their business over here. Some of these are cancer patients and so forth who are on special drugs and things like that.
The comments on Facebook in opposition of Rite Aid they're super frequent.
Yeah.
Just people just going off, and
Yeah.
then you open them up and read it, and it's everybody's saying to come here. They only have one other place to choose, but
Right.
they're not just saying, oh, just move to there. And they're giving like good, like reasons why and positive experiences. So it's really cool.
So we won't have to do a performa after all if it keeps.
Yeah.
It'll still be interesting to
I'll do
see
it anyway.
how much that actually means.
Amy and I talked about it today. We'll do that pro forma. Do a product line income statement for everything for next month. Then if we look at the bottom, productivities, FTEs, we are over on the FTEs, but we are under in the dollars because we are taking real good control of OT right now. At least we're in October. November, it went up a little bit, but October, we did a real good job of keeping OT down. And also what really is even better is that our contract labor is down and really our payroll hasn't increased that much. So that we're doing something right. So that we need to keep it up. Mark, I think you're doing a good job there. Something's going right there. Everything else, expenses are pretty close to budget, except for, as usual, the supply expense. And again, that is the pharmacy increase in scripts is going to be an increase in cost too. We are looking at our 340B program to try, we don't think we're realizing the benefits from it totally right now, because we should be seeing a decrease in cost, a bigger decrease in cost. What SUDA tells me is that we are seeing that decrease, but we have so much increase in prescriptions that we're not seeing it all the way. But I looked at the invoices and I don't know if that's true. We're going to get down and dig a little deeper. Michael Brazy and I are looking at that. And also we have something else later. We're talking about the attorneys we're going to get. I think they're going to help us. I think we're going to realize a lot more money out of this eventually. I just don't think we're taking full benefit of it right now. Let's see. That's everything else is pretty much on budget. Our expenses are total expenses for the month are about 2.6 over budget, and our expenses for the year to date are 0.25%, almost right on budget. About 33,000 over budget on 13 million, which is okay because our volumes have been up too. So you would expect them to go up a little bit more. Any questions on the income statement or the statistics? Amy, do you have anything to add too?
No, unless there's any questions.
Gene, do you have any questions?
Well,
Okay, I'll move on to the balance sheet now. The balance sheet, our cash is down a little bit because part of the reason is, well, it's going to go down even more because we are in November, we had our matching funds of about $4 million, a little bit more, and we won't be getting back to 8 million or so until January, February, depending on how quickly they do things. What they suggested that we do in the meeting that I had with the district leadership forum is once January comes, start talking to our payers and say, hey, we could use the money a little bit more quickly. So I don't know if we want to do that. We can when January comes around. We'll see how quickly they're going to move on this. But if not, we can light a little fire under them a little bit too to get the money a little more quickly. And the other thing, we have 1.2 million going out in December for a matching fund also. So our funds will be depleted for a while until they get refurbished in end of January, February.
Hey, John, do you anticipate any change to any of these programs with the new administration coming on?
Well, I don't know. He hasn't really talked about that. What scares me a little bit is the 340B program. I don't think they're going to do away with it, but there's been talk for the last couple of years that they want to do away with it. I don't know, Tim, if you know more about that than I do.
Yeah, what I'm hearing is that I know there's a congressional delegation that went to Washington just recently from CHA. They were actively pushing to continue to support 340B. They want to see that fix. So yeah, there's still strong support, especially coming out of the health sector for that. So good.
Okay. Everything else is pretty much the same, except somebody asked what our auxiliary cash balance was at October 31st. It is 412,075 as of October 31st.
Mark, can I say something about what you were talking about, Mark?
Yeah, go ahead.
GE1 Healthcare took a major hit on their stock because they felt like the money flow wasn't going to be there with this administration the way it has been.
He said change.
So we could experience more difficulty in getting money, if that's an indication.
Right, I don't know. Okay.
Thank you.
Okay. Any questions on the balance sheet?
I know that you're talking about the auxiliary cash. I know it probably looks kind of confusing because it looks like the totals are right there. But in auxiliary cash line 15, that total, it also includes auxiliary, diff trust accounts, and the Edison bond. So I know we're going to try to break it out on its own line and separate those out.
So what percentage of that is actually auxiliary though?
412,000.
Oh, 412. You said that. I'm sorry.
That's all right. But I mean, our cash is still pretty good. It'll be better once the new year starts.
What page is that auxiliary cash on?
Page 10.
Page 10.
Thank you.
Okay. Any questions on that? Okay.
Nope.
Amy, do you want to talk about the local vendors?
We jumped over there.
Actually, Amy, before you start, I just want to say something real quick. I don't want to say anything that's, personnel related. Me being in this position as the treasurer of the hospital board, I know the last couple of years has been very rocky in the financial department between Chet leaving and then Dave and Barbara, now John. So I'm just telling you and John that I appreciate everything you guys are doing. I know it gets very overwhelming at times. So I just want to say that as the treasurer, I appreciate you. I appreciate what John is doing. And I think anytime that you feel that you're overwhelmed, do not hesitate to ask this committee for help. We will get you.
Great, thank you.
Thank you. Yes. Thank you. Oh, a couple other things I forgot to mention. We are in the middle of an audit right now, and we're in the middle of the cost report also. The cost report will be done probably today or Friday. And usually last year was about $200,000 to the positive. I assume it's going to be somewhere in that range again. So we'll get a little bit of money out of that. Not a whole lot. Our Medicare percentage is not as big as it is it at some other hospitals. So our cost report does not have as big an effect as it does on some other hospitals, critical access hospitals especially.
And we usually do the audit in January, right? After the beginning of the year, usually January, February.
Yeah, we want to get it done.
Okay.
So
We were
right now
ready,
we
we were
have
ready for them.
It was probably late last year, if I remember correctly.
I think we ended that in March.
Yeah.
So.
Yeah, that's too late. We will try to push it even further next year, hopefully get it even started in September maybe, because if you have 6 months in between the numbers, it's a little bit late to do anything about it if we find something we want on the audit.
Yeah.
Okay. All right, Amy, the floor is all yours.
So
I think that's the.
there was no other questions on this financial statement, or we just jumping over?
Yeah.
We skip past the contract review.
We haven't got.
We haven't got
We haven't gotten there yet, Dean.
Okay, so for the local
Okay,
records,
okay.
on page 18. Everything's pretty normal. You're gonna start seeing our propane costs increase, but you'll see our Edison decrease. Pretty normal unless anybody has any questions.
I don't have any questions.
The pest control 680, it seems like it's going up a little, is it? And with the winter, with the cold weather, shouldn't it be cheaper because everything goes sort of hibernate or not? I don't know.
Decide to stay warm.
Yeah, there's other pests besides bugs that we're dealing with now.
For quite a while.
Okay, thank you.
I don't have any questions. Okay, now we'll get into the contract review. Page 19. Dean, did you have any question about any of the contract?
I had a question on Carrie, that very bottom one. Exactly what is that?
Oh,
Walters Blue or
That's software, I believe, for the physicians.
Is evidence-based clinical decision support resource.
Yeah.
I don't use it. It's something that they use at the medical staff level, so.
Right.
It's something that Dr. Finstad and Gross
Correct.
probably use.
ER doctors can get on it as well.
Okay. Oh,
I think it's sort of like a query that they can use to do research for a variety of clinical decisions that they may need to make. So it's kind of like a repository that they're
Okay.
able to reference.
It's WebMD.
it's not a duplication of anything.
No, it's a fancy WebMD. That's a good way to put it.
Okay. All right, that was my only question.
anything else on here that it's out of the ordinary. Gina, you okay with sending this to consent, the contracts?
Yes,
Unless there's any.
yes.
Okay. Okay. Move on to item 2, which is another CER request for med surge gas. Is this you, Tim, since Bob's not here?
Yeah, that's me. Bottom line is, yeah, we have, our medical air compressor in surgery, half of the pump went down, and so forth in that compressor. And so, obviously, we need to replace that. Again, we're still looking at ramping up surgery here sometime, soon. So, run with only one half of that system. So it's, Bob's gone out and tried to get bids on that. It's, again, because of the nature of company, it's basically sole source bid. It's $12,707.
Are you having fun with that?
Oh, the book is just totally wrong, so I winged it. And
Oh,
it was-
Hey, Christine,
Oh,
put
good.
on, you please.
oh, sorry. Hi, I'm sorry. I just, Kim just walked in, so I missed what you said.
You were not.
No, got confused because I muted her the same time she muted herself, so.
Oh, I'm sorry. Okay.
Okay.
Gene, do you have any comment about the CER request for the,
Air compressor,
yeah,
they've got some done at Harbor Freight that's cheaper.
Not medical quality.
That looks good to me. I don't, I know they've done their research, so looks great to me.
okay, we'll send that to consent.
Okay, great.
Yes,
We already did Stuart's CER request, so we'll go to item 4, which is 340B legal counsel proposals. That's pages 36 through 45.
Yeah, this is one of the things that we've been delving obviously more and more deeply into 340B program. It's an extremely complex process that we have to go through to basically maintain compliance with that program and so forth. And, we brought Mike Crazy and he went out and got his own training done for certification under 340B. Suit is going through that process as well. The one thing that came out of those certification processes is the need to have attorneys who understand 340B to guide us with this process and so forth. As a matter of fact, we've been getting audited by Express Scripts every couple of weeks. They're sending us a new audit on our purchases and those kinds of things. And as we were talking with one of the providers, which is Powers, the first one on here, he advises, says, there's a law that was passed in California this last year that basically makes that illegal for them to do that. They can't. So we spent a lot of time going back and looking at every one of those drug purchases and stuff like that to see whether it was done properly under 340B or not, or whatever. And so, like I said, it underscored the fact that we really do need help with this. Again, the 2 vendors here, we vetted those. John and I were on the phone with them. And so forth. Our preference of the 2 was to go with Powers, and they were out of Washington, D.C. The gentleman that we spoke with, this William von Ozen, actually helped write 340B for the government. And so he is the expert across the country on this thing. And so he's discounting his rates on there and so forth. But again, they have other staff that are working on this below them. They're the final review before anything goes out of their office and stuff like that to keep the costs down and so forth. And cost wise, I think the other contract with Quarles was very similarly priced. Obviously don't have the experience that Powers Group does. These guys represent a lot of the major 340B associations and so forth and hospitals within there, the major hospitals. So our preference would be to go with Powers and so forth, and just do that engagement
Especially since if they helped write it, they already understand the.
inside and out.
Yeah.
Inside and out. And so, so anyway, we just wanted to bring these here just so, again, we can keep this moving forward. As John said, again, we have some concerns as to how 340B, whether we're actually seeing the savings coming out of 340B. I've been looking at this and talking with John and going like, I said, we're seeing all this increases, but when we look at the expense side, again, if we're saying something that's going to be 6 cents a pill, and yet we're looking at, these numbers that we were getting, so we need some guidance from these guys on that, and just making sure that we're doing what we need to do. And so I think this is an absolute requirement if we're going to be in that program. And then we're going to monitor this to make sure that this isn't to pick up the phone and just call anytime we want. This is they're expensive rates and stuff like this, but we will pool our questions before we make a call or write a letter to them or whatever, just to keep those costs in check. But like I said, the advice that they will give us will be substantially beneficial to us in managing that program and doing it correctly. So, and I have, like I said, I know Stuart is absolutely supporting of this. She's chomping at the bit just to kind of get some things done. They will both help us with policies and procedures that we need to get written specific to our program and so forth. And just really to prevent any federal audits that are being done and stuff like this is really what we're trying to do. Make sure we stay compliant with the program. So,
And not leave any money on the table.
and not leaving money on the table, right?
I think we're also going to do a mock audit. I think Michael Brazy sent us an email on that, Tim.
Yes, yeah.
Separate, we use these guys for that too.
Well, yeah, they'll help us with that. So
They'll help us with that, but they won't do it. But I think somebody else is doing it actually. That's cheaper, but they will help us and interpret the findings probably too, I'm sure.
yes,
Hey, Kim,
yes.
who will ultimately be in charge of that? Who, like you said, we can depend on them for guidance, but for what they charge, all we need is laser guidance. I mean.
Yeah, agreed. I've asked John to take over responsibility for 340B just because of the monies that are involved with that program. He has more experience with 340B from his last hospital and so forth. So John's agreed to do that. He's been working very closely with Michael and with Suda on this. So he will be the one in charge of that.
It sounds like something that could make us a lot of money. Could that merit like a little committee of maybe Suda and John and you?
Yep.
And maybe even one board member or something?
We have committees on this already.
We do.
Oh, okay, cool.
Weekly, yeah.
Then
Yeah.
it sounds like a really good thing.
Yeah.
It's just we can't depend on them to do any work.
Yeah, right. No, that's just the guidance. Take a look at what we're doing. It's a yes or no. Here's what you need to do. Make sure this is in there, that kind of thing.
Okay.
Like I said, as we looked at the building prices yesterday, that, if we ever hope to want to be able to build a new pharmacy down there, this has got to be working perfectly to get that cash
Yeah.
flow.
Right.
So,
Okay, then John, I'm for it the way it's written.
Okay, yeah, I am too. And them being based in Washington DC, if there's any changes to the law, they can just go.
Yeah.
Vince Vaughn store and that.
He'll probably be making the changes to the laws actually, if anybody's writing it.
right.
Yeah.
So, and most of the expenses will probably be on the front end. Once we get advice from them and the policies, our use of them probably will dwindle a little bit.
And like I said, they're actively involved with the 340B committees around the country, the industry committees, and so forth, advising them as well of the changes that are coming down the pike and so forth. So that's why I think it's great to have them, if we get them on board up front, so we can learn of these changes before they come, so we can adapt quickly to any of this stuff as it happens.
Was this $5,000 retainer just the one time to get it set up and then
It's not maintain a 5,000. So if we use 2,000 of that 1 month, we
got to replenish it.
that guy, correct?
Okay. All right, well, we'll send this to board consent.
Okay, that'd be great. Thank you.
And the last item is the emergency department position coverage overlap.
Yeah, this one here, I didn't have it printed on this one. What we are had a long-term conversation with Dr. Hall, our medical director. And one of the issues right now is the way our ER physician payments are structured. They get paid, they do 2 shifts of 12 hours, a morning shift, the day shift and a night shift, and so forth. And what happens is, depending upon how busy a shift that we have, they may not be able to get their charts finished and those kinds of things. And so what he's suggesting or asking for permission to do is to, instead of going 12 hours a day, is to give them 1 extra hour per shift to kind of stay after, get their work done, and so forth, or to help come either as they come in, some of them come in early, like Dr. Burrows does, to kind of help clear out some of the backload of what's coming on before him, because sometimes they get dumped on from the people that are operating before them, and so forth. And so, we had talked about doing that because we have a couple providers that are very slow with doing that. We're in the process right now of trying to gradually change some of our physician coverage. I've talked about that in a couple of meetings already, and trying to bring in some new physicians. And so this is something, like I said, that he's proposing again, because right now there's a lot of pressure being made to increase reimbursement for ED physicians. Our rates, even though we did a significant increase this last year, and so forth, they're probably up about $50 to $100 an hour more than that now. And so as we've learned that, especially as we've been talking to some of the recruiting companies, Medicus is one specifically that we've spoken with, and we've got 2 others that we're talking with also. But he felt this is a way, like I said, by giving them this extra hour, because right now what they do is if they have to stay over, that's unpaid. So they can spend another couple hours in here without pay, having to get that work done because it was technically part of their work. But again, if they took work on from the prior physician that precluded them from getting that done, then they get hit by that. And so that's become a big deterrent. So instead of going in and suggesting big increases into the rates right now, is to give them this 1 hour extra per day, on each shift, in order to make that work. I think John and I both calculated, we're looking at about $160,000 a year. So what's that work out to on a monthly basis? 12,000, 13,000, something like that.
13, yep, 13.
So in the grand scheme of versus increasing their hourly rates, this would make a lot more sense.
We may gain something out of it too. If they're diligently documenting things, we may get some more charges and some more reimbursement out of it too.
True. True. So.
Sounds like goodwill, and it could be a positive thing to work with them the best we can.
I agree.
One of the other things that I think from the clinical side is the continuity of care that continues with programs like where you have 2 physicians at the peak hours.
Yes.
Is a very good benefit to the community and to the clinical side.
Interestingly enough, I know Chris had mentioned and speaking with the nurses that the nursing staff back there was actually very supportive of it, because now for a brief period, they've got 2 physicians.
That's right.
To kind of help clear some of this out, to kind of help them out as well.
Yeah, so they can fast track some of those during.
Yeah.
I just see added expenses though, $160,000 a year.
Mark,
Yeah.
Already.
can I ask Mark a question?
What's that?
It's more about the emergency. Can I ask Mark a question?
Yeah, go ahead, Gene.
Have we had a lot more emergency room visits since November 5th? There's reported that people are banging their heads against the wall. And I just wondered if it was creating emergency activities.
No, they're not coming in to get seen, just saying.
We're actually under budget. Your month to date, Gene, we're under budget in ER.
Gene it was a joke.
He was.
Maybe we need another election then.
Oh, no, I just say added expenses. And it's
Oh, I
going
know.
up.
Trust me, we don't like doing that, at all, at any time. But like I said, I think we're going to be up, we're going to be looking at some big increases probably anyway. If we have to start replacing some of these guys, to keep them in line with what's going on in the market. And that's our concern right now. So if we can mitigate that for a while by doing this, then I think it would behave us in the long run.
Was there any concern with, like you were saying, like they look at their charts when they're not getting paid for that time. Is there any concern with like labor law problems with that or
No.
because they're independent contractors?
Independent contractor.
Okay.
Right. Yep. And it's medically their responsibility. So part of that, so.
Okay. And are we going to talk about this at the next board meeting?
Yeah.
Like a formal action or something?
Yes.
Okay, so this will go on new business for.
Right.
Okay. Hey, Gene, do you have anything else?
No, that's, we agreed to do the, what Tim's been talking about, right?
Yeah, it'll go on the board for new business.
Consent.
It will actually go on to
Right,
new
right.
business for the full board to discuss and
Yeah.
take action on.
Okay,
Yep.
good. Okay, no, that's it.
Okay.
That's all I had. So I guess we will adjourn at 1:41 and happy Thanksgiving.
Go win us some more money, Gene.
Yeah.
Good to talk to you. Thank you.